At some point a number of years ago, I decided that what I'd like to do when I grow up is to work to try to increase the quantity and the quality and value of implementation science. This was based on some experience within the Department of Veterans Affairs and the VA Query Initiative in its work to increase the impact and the uptake of research to improve veteran health care. And I recognize through a series of conversations with colleagues that the clinical research is not enough, that these findings and innovations are not self-implementing, that there is a science of implementation, and that science, as I indicated, needs a fair amount of effort to increase, as I said, both the quantity as well as the quality. As a consequence, each time I'm given an opportunity to speak and participate and contribute to a meeting like this, it's a chance that I jump at. Obviously, the close proximity to my home base in Los Angeles, as well as the beauty of the setting, were factors as well. But I do appreciate the opportunity. But my task is a little bit different, somewhat more mundane, I suppose, than that Dennis was given, and that is to provide a set of frameworks and ways of thinking about what is implementation science, why is it important, how do we go about thinking about the design and conduct of implementation studies, and perhaps more importantly, what is it about the field and the way that we are conducting our implementation studies that has left us in a situation of somewhat limited impact. We have a very large body of work, but I think it's fair to say if we take a half full versus half empty sort of perspective on the field, that we're very much on the half empty side, that we have much to do, that the impacts and the benefits of the increase in quantity of implementation science activity haven't yet realized or yield the benefits that we need. And much of my talk will focus on presenting a set of frameworks and a set of answers to the question, why is it that the implementation science work has not yet led us to, some might say, a cure for cancer, as a way of highlighting the difficulty and the challenges associated with the problem. But I think it's fair to say, and I know many of the speakers over the course of the next couple of days will reinforce this idea, it's fair to say that we could be doing things somewhat differently in order to enhance the value of what we do. As I said, though, I began at the VA, U.S. Department of Veterans Affairs, affiliated with the Query Program, or a Quality Enhancement Research Initiative. And that was a program that was designed to bridge the research practice gap, to contribute to the VA's transformation that most of you, I'm sure, are familiar with during the 90s, and try to focus the efforts and energies and attention of the health services research community within VA on the problems and issues of the transformation of the healthcare delivery system. Primarily due to health reform, all of a sudden within the health sector we see a great deal of comparable interest outside VA. So I've been in the position of basically essentially representing or carrying some of the insights and trial and error learning experiences from VA in systems like Kaiser Permanente, the UCLA healthcare system, that are interested in trying to understand and replicate what VA accomplished, and to do so in perhaps 2 to 3 years rather than 20 to 30. I've been given opportunities to help share some of those experiences. In some ways, I often feel somewhat like a management consultant. Back when I was at business school getting my PhD, the MBA students used to talk about the management consultation occupation and the job opportunities, and in the shorthand label or description of that occupation was that a management consultant essentially steals ideas from one client and sells them to another. In some ways, that's what I do lately between VA, Kaiser, and UCLA, but it's all with full transparency. They all recognize both the contributions as well as the benefits, and I think it's all above board. So let me move on and provide you with what I feel is a summary of the key topics or the categories of knowledge that I hope will be covered during the conference, and that to me represent basically what the field of implementation science is all about. So my hope is that at the end of this conference you have a very good sense as to what implementation science is, what its primary aims are, what the scope of the field is. Why is it important? What are some of the key policy, practice, and science goals for the field? How does it relate to other types of health research? And as a researcher with a PhD, a social scientist working in a healthcare delivery system and health setting, the bulk of my work and what I know about is health. I know that the work that you do is at the intersection between health and some of the social services and other sectors. So if you will excuse my focus on health and perform the translation in your own minds from clinical and medical issues to the broader set of issues, that would save me from the burden of trying to do that on my own and speaking about issues that I don't know much about. In addition to the question of how does it relate to other types of health research, one of the key areas of focus of the query program in my presentation will be item number 4. What are the components of an integrated, comprehensive program of implementation research? What are the kinds of studies that we need to think about in order to move from the evidence, the kernels, the programs to implementation and impact? And that is actually a bit of a challenge, in part because the components of the integrated comprehensive portfolio are somewhat different from what we see in other fields. And then finally, the broad set of questions: how does one go about planning and designing, conducting and reporting the different types of implementation studies? I will not touch much on that issue at all, but that is, again, the focus of much of the other talks. So Dennis covered the first 2 issues. What is implementation science? Why is it important? What I'd like to do is focus primarily on questions 3 and 4. I will spend some time talking about number 1 and some time 5 as well. But my focus, again, will be primarily how does implementation science relate to other categories of health-related research, social science, social service research, and what are the components of an integrated program. So let me go through a set of slides that provide different ways of thinking about what implementation research is all about and why it's important. And these are all somewhat different, but largely complementary. This is the usual story that we see and the usual way that we think about implementation research, and it's a story that for the most part does not have a happy ending, and I'll say more about that in a minute. But generally speaking, what we see is the introduction or development, the publication of a new treatment, a new innovation, new evidence. Often, at the time that that innovation is released, we do see some modest efforts towards implementation. Most of those efforts focus on dissemination, increasing awareness. We see press releases that follow the publication of the journal articles. In the health field, we often see greater impacts on clinician awareness when studies are reported in the New York Times or Time magazine than we do in the original journals. There are often editorials that are published that accompany the release of the new findings that point out the importance of ensuring that they are adopted and used by the practicing clinicians. But by and large, these are relatively modest efforts towards implementation, and they focus primarily on dissemination, increasing awareness, with the assumption that awareness will lead to adoption and implementation, an assumption that we know, by virtue of all of us being in this room, is not valid. A number of years later, we will often see articles published that measured rates of adoption and for the most part show that significant implementation gaps or quality gaps exist. So yes, there was the publication of this large definitive landmark study. Yes, there were press releases, efforts on the part of the specialty societies and other professional associations to publicize and increase awareness. There were at best small increases in adoption, and oftentimes there are no increases in adoption. That finding, the documentation of those quality implementation gaps, is the usual trigger for implementation studies. And those implementation studies tend to be large trials, often without the kind of pilot studies and single-site studies that Dennis talked about and that I will discuss briefly as well. Those are large trials that evaluate specific implementation strategies or programs, practice change programs, quality improvement strategies that attempt to increase adoption. And the reason that this story typically has an unhappy ending is those large trials of implementation strategies tend to show no results. So not only do we see a lack of naturally occurring uptake and adoption, but even when we go about explicitly and intensively, proactively trying to achieve implementation, more often than not, or more often than we would like, those efforts fail. And it's that unhappy ending that I will talk about with some of the frameworks and try to explain what it is about the way that we are going about designing, conducting, reporting, and following up on implementation studies that may contribute to those disappointing results. I'll also point out that implementation programs or strategies, quality improvement, practice change, there are a number of different terms. I tend to use them all interchangeably, and I'll actually talk a little bit about the so-called Tower of Babel problem as well. So let me go through a set of slides again that provide a number of slightly different ways of thinking about what implementation research is all about. This is a set of simplified diagrams that really derive from some work of the Institute of Medicine Clinical Research Roundtable about 15 years ago, as well as the NIH Roadmap Initiative, again in the medical health field, that basically depict the distinction between what we would like to see in a well-functioning, efficient, effective health research program, and that is basic science and lab research that very quickly leads to clinical studies that attempt to translate those basic science findings and insights into effective clinical treatments. Some subset of those clinical studies do, in fact, find effectiveness of innovative clinical treatments. They're published, they are publicized, disseminated, and we see the improvements in health outcomes. As opposed to that idealized or preferred sequence of events, what we tend to see is depicted by the bottom set of arrows. Now the yellow arrows, if you can see those, depict the idea that some proportion of basic science findings as well as clinical findings in fact should not lead to subsequent follow-up because they don't have any value. There's no reason to follow up. A treatment, a therapeutic approach that we evaluate for which the harms exceed the benefits is one that should be published, should be well known, but of course will not lead to improved health. So the yellow arrows are to be expected, they are appropriate. It's the red arrows that we'd like to eliminate. The findings that are published, that have some value, that sit on a shelf for some number of years, and then eventually are taken up and moved into the next phases. This is just another way of depicting these different activities, and of course in the NIH Roadmap Initiative, and those of you who are familiar with medical school and university campuses that have funding from NIH for a CTSA or CTSI, the NIH Clinical Translational Science Award Program, the bulk of that funding and the bulk of the NIH investment, as is usually the case, focuses on type 1 translation, translating basic science findings into effective clinical treatments. Some label this feeding the pipelines of the drug companies. I won't spend any time down that path, but the point is that much of the NIH investment is in the type 1 translation. Our interest, of course, is in type 2 translation. Understanding the roadblocks that prevent a significant proportion of the innovative treatments and findings from clinical research moving into clinical practice and achieving their intended or hypothetical or potential benefits and impacts. So for the rest of my talk and the rest of the conference, for the most part, the focus will be on this so-called type 2 translation, the second translational roadblock. One of the important distinctions, in a distinction that is often not clearly made in research, is between clinical research or clinical trials versus implementation research. And this is one table that attempts to capture some of the key features of both categories of research and helps us understand when we are conducting clinical research, when we are conducting implementation research, and when in some cases we're conducting hybrid studies that combine elements of both. For the most part, the study aims of a clinical study, a clinical trial, are to evaluate a specific clinical intervention, a treatment, a therapeutic approach, a prevention approach, management of a clinical condition. The focus of those studies is on the effectiveness or the efficacy of that clinical intervention. These are drugs, procedures, different forms of therapy. The primary outcomes that we hope to affect through clinical studies through the use of this clinical treatment are symptoms and health outcomes. The unit of analysis, the unit of randomization in most of these studies is that of the patient. So we are evaluating a new therapeutic approach, a new school-based program, violence prevention, any number of kinds of programs or interventions. The term clinical research is used somewhat broadly to capture that type of research. This is in very distinct contrast to implementation studies where the focus is not on a clinical intervention, but instead on an implementation intervention, a practice change, a quality improvement intervention. Our focus in this case is on the adoption and the uptake, the use of that clinical intervention by the clinicians, by the teachers, by the counselors, or by the organizations, the institutions, the entities that are delivering that program. In this case, our interest is ultimately in achieving improvements in symptoms and health outcomes, but that's a distal outcome and goal. The proximal outcome and goal of the implementation studies is to improve rates of adoption, improve adherence to an evidence-based clinical practice guideline, improve the fidelity of delivery of that program. And of course, in this case, the unit of analysis is not the patient, but instead the target of the intervention, and that is a clinician, a therapist, a teacher, a counselor, a team, a facility. So this set of distinctions is important in clarifying what it is that we are doing, what are we trying to achieve. And the reason, in part, to be very clear about this distinction is that different theories, different kinds of research designs, different evaluation approaches, different outcome measures are applicable to clinical research versus implementation. So these are distinct categories of research, although again, it is possible in some cases to combine elements of both. But if that is done, and I'll talk about hybrid designs in a moment that are hybrid effectiveness implementation studies, it's still important to distinguish the aims, the goals, the outcomes, randomization, and so on. So yet another way of thinking about implementation science is the definition that Martin Eccles and I published in the opening editorial to the journal Implementation Science in 2006. And this was adapted from previous definitions. And it's a two-part definition. The first part states that implementation science or implementation research is the study of specific methods or practice change strategies to promote uptake of research findings and practices into routine care settings. The goal, of course, is to improve the quality and effectiveness of the outcomes of health services. Implementation science also includes the study of influences on healthcare professional and organizational behavior, and I've highlighted that in blue because, in fact, when we were debating the title and the scope of implementation science, we had a great deal of discussion and actually not as much consensus as would have been ideal over the definition, over the term, and over the scope. And we decided to use the title Implementation Science, but in fact it would have been more appropriate for us to label the journal Implementation Science and Health, because the focus of that journal is on health, and it actually in some ways ignores the fact that there is implementation science in a number of other social sectors in other fields and domains. And Dean Fixon was among those who was most vocal in advocating a broader scope for a number of reasons, including the fact that the publisher that we decided to partner with, Biomed Central, was a biomedical publisher. We decided to limit the focus and the scope on health. But there has been continuing debate in the Global Implementation Conference that Leslie and Nancy had mentioned, where we first met, did have a broader scope. We continued to debate within the implementation science and health field how much effort we should make to reach out to our colleagues in other sectors. One argument states that there are too many differences in those sectors to allow for productive interactions, and it would be more confusing than beneficial to collaborate and try to achieve cross-fertilization. My response and my view is, look, if we were doing fine on our own in the health field, it would be okay for us to say, we've got this covered, let's not confuse ourselves. The fact is we don't have it covered. There is a wealth of insights and approaches that we could begin to import and benefit from in other fields, and we actually should be doing more of the sort of thing that you were doing right now, which is to bring together a group of individuals who come from different fields and begin to exchange better ideas. I saw an announcement just recently for the 2015 Global Implementation Conference, which I hope many of you will have an opportunity to attend and contribute to this cross-fertilization process that we sorely need. So this is a restatement of the definition of implementation science, which again is a way of trying to convey what implementation science is all about. I believe if we were to go back and perform some sort of content analysis on the last 2 to 3 or more years of publications in the journal Implementation Science, the vast majority of them would fit very nicely into one or more of these categories. Implementation science aims to develop strategies for improving health-related processes and ultimately outcomes, and to achieve the adoption of these strategies. This aim maps to the first definition on my previous slide. It focuses on the interventions, the practice change strategies. The field also, though, has more of an observational or a basic science orientation and set of aims to produce insights and knowledge regarding implementation processes. How does implementation occur in natural settings, under natural circumstances? What are the kinds of barriers and facilitators to implementation, to greater adoption of evidence-based practices, effective practices? And what are the specific strategies that we can employ? And finally, as with any field of science, implementation science aims to develop, test, and refine theories and hypotheses, and to develop methods and measures. So again, another way of thinking about the question, what is implementation science all about? What is its scope? And this is one answer to that question. I mentioned earlier the Tower of Babel problem. It's continuing to plague the field. It has to do with historical origins of the field, but basically does represent an impediment to greater progress. We see far too much work published under different labels. Again, there are competing kinds of arguments or views or philosophies here, one of which says, look, the field came from a number of different origins. All of us in the field just need to take the time to become familiar with these terms so that we can find the research and understand what our colleagues are doing and to integrate that research ourselves. The counter-argument, which again is the one that I subscribe to, says we have a problem that is not only one that's internal to us but also external. And we need to clearly state what it is that we do, to highlight and explain its importance, and to achieve better recognition and legitimacy and support. And we can't do that if we are speaking different languages. And we need to somehow forge some sort of consensus and limit the scope of terms that we use. I have another issue with what I often refer to as the T-word translation. And that comes from a number of concerns, one of which is that Type 1 translation and Type 2 translation are very different kinds of research. Using the same term to describe both of those leads to confusion. The other problem is somewhat different, and that is that there's an implication when we say knowledge translation, and this is not necessarily an implication that is perceived by all, but to me it has the sort of feeling of we as researchers and academics possess knowledge that we need to translate to our perhaps less capable policy and practice colleagues. Now, knowledge transfer and exchange actually gets around that by talking about and implying that there is knowledge on both sides and we need to transfer and exchange. But knowledge translation tends to imply this issue of a one-way transfer of knowledge and a translation to a dumbing down of that knowledge. So for all of these reasons, I've been on what seems at some times to be a bit of a one-man campaign to stamp out use of the T-word. But I think for the sake of clarity and consensus and consistency, to present a unified front to our policy and practice colleagues and other stakeholders, it would be very beneficial for us to try to reduce the number of terms and to reach some consensus on what this field is all about. And the result of this debate within the planning committee that launched Implementation Science, the journal, of course, was implementation science rather than other terms. So let me briefly talk about one other area of confusion and one other area that requires more work and more thinking in efforts to forge consensus, and that is the distinctions between implementation research or implementation science and quality improvement. And there are a number of differences, and again, there are as many different opinions on these issues as there are researchers active in the field, or nearly so. But for the most part, quality improvement tends to focus on specific quality problems that need to be addressed and solved right now. And a common approach to quality improvement is to continue in an iterative manner to try different solutions until we solve the problem. And it's a valid and appropriate approach because, as will become clear later in my talk, but especially in some of the others, the breadth of barriers that we face and the number of different solutions and factors that influence successful practice change is very large. And we rarely can correctly guess first time out what it is that we need in order to close a quality gap to change a practice. And so we do need to continually try different things, evaluate their effect, and in this rapid cycle, iterative manner, continue to work until we solve the problem. And that's, in some sense, what quality improvement is all about. It's motivated by a quality problem and a need to solve that problem. Implementation science tends to be motivated or to begin not with the problem, but instead the solution, the evidence-based innovative practice or innovation, and the idea that that innovation, in order to achieve its benefit, requires proactive efforts to achieve implementation. So it starts from the solution and forges ahead in the practice change direction. As a scientific field, in quotes, it attempts to develop and rigorously evaluate an implementation strategy across multiple sites, not solving a single quality problem, and to do so in a way that is generalizable, and to develop generalizable knowledge at the same time. In the interest of time, I'd like to go on. There perhaps will be time either during questions or later to debate this more thoroughly. But again, it's another area of somewhat limited consensus and confusion within the field that relates back to the Tower of Babel problem. So let me return to this diagram and then go through a set of slides that attempt to illustrate some of the gaps in the pipeline, some of the reasons why this very simple linear sequence is often not effective in closing implementation gaps and leading to increased adoption and uptake of the evidence-based practices that we attempt to sell and purvey. So the first gap in the pipeline is our thinking about what we mean by clinical research. And in some ways, this is not a gap. It's simply an elaboration or an explanation of what I mean when I say clinical research and what that center of the main large pipeline is all about. It's not just clinical research on drugs and devices, but health behavior research, health services research. Much of the work that you do would fall under the health behavior category. But again, there are many other categories of clinical efficacy and effectiveness research in different bodies and different domains, social service sectors, that are generating new innovations, innovative treatments and strategies. That is all the focus of, again, what I label clinical research. Now, the next gap that I'd like to talk about is one that I know Larry Green will address, and he and Russ Glasgow have written quite convincingly and eloquently about, and that is the distinction between clinical efficacy and clinical effectiveness studies. As implementation researchers, we will often lament the fact, the observation that the newest, latest, greatest finding to be published is not greeted with extreme enthusiasm by the target clinicians whose behavior we hope to change, and they're not quick to jump and change their practice immediately. And our conclusion is, what is wrong with these clinicians who don't recognize and subscribe to evidence-based practice? Why aren't they adopting this finding? Well, they've been around long enough to know they just need to wait another 3 months or 6 months, and yet another definitive, groundbreaking study will come out that shows the opposite finding. And again, Larry will talk about this later on, but the bottom line is efficacy studies are not ready for prime time, the results of those studies. We need to wait until we see the effectiveness studies that tell us something about whether and how this practice operates under real-world circumstances. But we also, equally importantly, need to wait for the evidence syntheses or the evidence-based clinical practice guidelines that build on an entire body of research and attempt to synthesize that research and develop conclusions that tell us something with a level of confidence that we typically don't have from individual studies. There are many other arguments and many other reasons to focus on the effectiveness studies. In some fields within the medical research community, for example, there are studies that attempt to estimate the proportion of all patients that meet inclusion criteria in some of the so-called large definitive clinical studies. And numbers of 15 and 20% are not uncommon. So again, the practicing clinicians, in some ways, in many circumstances, know a bit better than we do as academics, that the so-called definitive findings are not necessarily definitive, but perhaps more importantly, they're not necessarily relevant to their settings, their populations, and the kinds of real-world constraints and circumstances that they fit. So as an implementation researcher, we could argue that the problem is not with us and our inability to develop innovative, effective implementation strategies. The problem is with the goods that we're given, that the research results, the evidence-based practices are not ready for implementation. Well, as with many statements in this field, there, of course, is some truth to that. So we can point the blame to those who precede us, but it's not all their fault. So let me move to the next gap in the pipeline, and this begins to move into the realm of the implementation researchers and what it is that we do or don't do that might contribute to the limited effectiveness and success of our implementation strategies. And that is depicted by the middle segment of the pipe, document and diagnose quality gaps. The patient safety folks have figured this out and basically don't proceed with a patient safety improvement strategy without conducting a root cause analysis. Most clinicians in medicine and other fields don't proceed with a treatment before they've completed a diagnosis. Back in the 70s and 80s, and still far too often today in the quality improvement and implementation science fields, we jump immediately to the treatment phase without taking the time to conduct the proper documentation and diagnosis phase, to conduct the root cause analysis, to truly document or diagnose rather the causes of the quality gaps or the implementation gaps that we're trying to close. There is a Cochrane Collaboration Review Group in the implementation science field that attempts to synthesize results of studies that evaluate specific implementation strategies. These include opinion leader strategies that involve a respected clinician trying to convince targeted clinicians to use a new practice. They include audit and feedback strategies that involve documentation of practices relative to the evidence-based guidelines and showing clinicians how often they follow or do not follow the guideline. Implementation strategies that are synthesized by the Cochrane Review Group also include computerized reminders, which in settings like VA and Kaiser involve a point of care reminder that reminds them of the appropriate evidence-based practice. And again, the Cochrane Review Group attempts to synthesize the relatively small but growing number of rigorous trials that evaluate those strategies. And the typical finding of those evidence syntheses, the meta-analyses, is very weak effects and high levels of heterogeneity. These strategies seem to work in some circumstances and for some problems, but not others. The problem with that sort of approach and that way of thinking about implementation strategies as interventions is that it's comparable in some sense to the idea that one would conduct a meta-analysis of the effects of aspirin for treatment of headache and fever and HIV/AIDS and diabetes and language disorders and a number of others. Those clinical treatment, those interventions are not meant to be cure-alls that are relevant to all problems. If we take the time to diagnose and identify the root causes of the quality gaps, of the implementation gaps, then we can sit down and think about an appropriate strategy rather than going to some list of effective implementation strategies and pulling off the strategies that seem to have the highest pooled effect size. So that example or that dimension of heterogeneity in the settings, in the problems, in the target clinicians, and the appropriate matching of a practice change strategy to the characteristics of the problem is one that we tend to ignore too often in the field of implementation science. In this middle segment, the need to fully document and diagnose the quality gaps before we move into the stage of proposing and then evaluating an implementation strategy is one of the gaps in the pipeline that offers at least a partial explanation as to why it is that our implementation studies don't lead to significant sustainable practice change. So again, the problem is not just those who feed us evidence-based practices and that they try to sell us efficacy findings rather than effectiveness. The problem also lies in the way that we take those findings or those innovations and attempt to implement them. This is a part of a broader framework that is covered in one of the articles that I will list that talks about the specific steps that we follow in the VA's Quality Enhancement Research Initiative, the QUERY program. And this focuses specifically on this middle segment in the previous slide, the individual steps in documenting and diagnosing quality gaps or implementation gaps or performance gaps. And again, in the interest of time, I won't go through this in detail, but as with many of the other frameworks, it serves as a roadmap, in a sense, of the kinds of steps that are needed in order to fully understand and address quality problems and evaluate solutions to those quality and implementation problems. So this diagram and the looping arrow over the top is what's new here, is meant to point out the fact that even though in many cases we do need to intensively and explicitly try to implement new practices at the same time that we within VA and Kaiser, for example, are working hard to design our implementation studies and submit grant applications and wait for funding, try to convince the sites that had agreed a year ago to participate that they should still participate, and doing everything we can to try to achieve successful practice change. At the same time that we are going through that process, practice leaders and policy leaders back in Washington are implementing new programs within VA all the time. And the number of insights that can be derived from those naturally occurring or those policy and practice-led implementation efforts are often much greater than the kinds of insights that we can and often are not able to derive from our experimental studies. Dennis mentioned earlier in response to one of the questions the problem of grant reviewers not liking to fund the single case studies, the observational studies and so on. One of the reasons that we don't see more observational studies is not only the fact that reviewers don't like to fund them, but researchers don't like to conduct them. You know, everyone is interested in developing the latest, greatest effective strategy in evaluating that strategy using the so-called gold standard RCT approach with an emphasis on internal validity and showing a significant change. The problem with these trials in the experimental as opposed to the observational trials is that they tend to be very artificial when they're researcher-led. As researchers, we identify a set of priorities and we attempt to convince our practice and policy colleagues to pursue those priorities, which may not be theirs. The observational studies maximize external validity because they rely on the study of what naturally occurs rather than what is occurring in a researcher-based led manner. They allow us to use much larger sample sizes and maximize our power to detect the contextual influences. I talked earlier about heterogeneity. There is considerable heterogeneity across different clinics and hospitals within VA, across different schools, across different clinics within Kaiser. If we have 10 or 12 key contextual factors that may include organizational culture and size and staffing composition and leadership turnover and budget sufficiency and stability and staff stability. By the time we get to a dozen of those, our ability to understand the influence of those contextual factors in a typical RCT, where we're limited oftentimes because of cost considerations to 20, 30 sites, is quite limited. In the Department of Veterans Affairs, with about 150 hospitals and close to 1,000 outpatient clinics, and with a good electronic data system, we have the ability to understand the effects of those contextual factors. And oftentimes in the implementation world, the main effect of the practice change intervention is much weaker than the effect of the contextual factors. There's an extreme version of this argument that basically states if we're trying to change practice or improve quality in a medical setting, it actually doesn't matter much which implementation strategy we use. What matters is the kind of leadership that is in place in the settings, the kind of staff expertise and commitment, the culture, and so on, those contextual factors. That has some significant implications for power and study design, but again, it points out the importance of contextual influences. Again, to use a clinical parallel, it's comparable to saying if a patient presents to us with a given chronic disease, it actually doesn't matter much which medication we decide to prescribe. What matters is that patient's home environment and whether it's stable, whether they have a good job, supportive spouse, live in a neighborhood where they have access to good food and exercise and so on. It's all of those other factors. And of course, in the clinical world, those other factors or contextual factors are important, but the main effect of the intervention, of the treatment itself, is important as well. In the implementation world, oftentimes the effect of that treatment is relatively weak. And the observational approaches allow us to understand those contextual factors. They also allow us to understand local adaptation processes and the effects of those. Pills can't be modified. They come in a bottle. We can perhaps prescribe them in the morning or night with or without orange juice. We can prescribe some supportive therapies, but we don't have the ability to modify the composition of that pill. Implementation strategies, practice change strategies can be modified. They are modified and adapted. They should be modified and adapted, and we should be studying how to guide that adaptation rather than ignoring it or attempting to achieve artificial fidelity to a program that doesn't fit many of the settings in which we study it. And again, the observational approaches allow us to study and understand those adaptation processes. So let me go through just one final framework, and then we should have about 10 minutes or so for questions. So although I've argued that in many cases we should prefer to study naturally occurring implementation processes using observational studies, there are instances where we do need to use an experimental or interventional approach. In the lower right-hand corner, for those of you who can see the wording, is an attempt to specify a sequence of experimental studies or trials that will allow us to make better progress in the implementation world. And there are basically 4 phases. This is a framework that is based in part on the FDA 4-phase framework for drug trials, as well as the UK Medical Research Council framework for evaluating complex interventions. It draws on elements from both, but is not precisely the same as both. And this, which is my last slide, is an attempt in words to describe the different phases. And it points out again under phase 1 the need for us to conduct the single-site case studies. In the VA's query program, the Quality Enhancement Research Initiative, which we launched in 1998, there was a great deal of pressure to show impact and show value very quickly. As good medical researchers, we as query researchers very quickly designed large, rigorous, randomized trials of implementation strategies, and we very quickly learned very large lessons as to why those implementation strategies were not likely to be effective. We discovered some barriers and some flaws and limitations in those practice change strategies very quickly. But these were trials. And in a trial, you maintain fidelity and you maintain fixed features of the study so that you can show with high levels of internal validity the intervention control differences. And there was reluctance to allow for any of the modifications that in many cases were staring at us very clearly as to what was needed. The single-site pilots, or 2 or 3 site pilots, allow us to learn those quick lessons very cheaply and quickly, 2 to 3 months. Now, the issue of funding, within VA we have the advantage of core funds that are provided to the query centers that allow them to fund these pilots internally without going through a 6 to 12-month grant process. It may be, as was suggested, that that's a potential role for the foundation. But again, we need to continue to work on NIH and NSF and our other funding agencies to point out to them that moving immediately to a 3-year or 5-year $500,000 or $5 million RCT without first doing the pilot funding is inappropriate and a waste of the research funds, as well as the time and effort of those sites that are participating. So we need to begin with those phase 1 pilots. We then need to move into the efficacy-oriented small-scale trials that will tell us something about the likely or theoretical effectiveness of a given practice change strategy under best-case circumstances, which in the case of implementation studies that are funded with grant support often means high levels of study team involvement at the local sites in providing technical assistance and support, in exhorting the staff to keep with the program and follow the protocol. Oftentimes the funds are used to support new staff and to provide for the training and supervision. We have Hawthorne effects due to that ever presence of the research team and the measurement. So as with any efficacy study, this is a method for evaluating whether under best case circumstances a practice change strategy can be effective. We often in the implementation field complete those studies, write them up, and essentially brag a bit about our success in improving quality. And then we walk away and go on to the next innovation, the next innovative practice change strategy. But as is the case with the clinical studies that we use to develop new evidence and innovations, the efficacy-oriented studies are not enough. We need to follow those with an effectiveness study, where the grant support does not provide additional resources, where the study team is not on site on a weekly or monthly or daily basis, and where we have conditions of effectiveness research. And we need to demonstrate in a much larger, more heterogeneous, more representative sample of settings and circumstances that this innovative practice change strategy can be effective. Then and only then can we turn over that practice change strategy, in the case of VA, to VA headquarters and encourage the National Program Office that's responsible for quality improvement, for example, in HIV/AIDS care, to deploy that program nationally. And at that point, as with any kind of phase 4 study, our role as researchers is to provide arm's length monitoring and help to observe and understand how the program is proceeding, whether it warrants refinement, what are some of the areas where the program seems to be working better than others and why that is. So again, another framework that serves to guide the design and conduct of an integrated portfolio of implementation studies. Now, before concluding, what I should say is that these are idealized frameworks. Many of them, in fact, are not completely feasible because the number of years that would take us to go through each of these is beyond what we should be spending. I mentioned, but actually didn't talk about hybrid studies that combine elements of clinical effectiveness and implementation research. There are also hybrid studies that combine elements of pilots in phase 1 or phase 1 and phase 2. These are also very linear, rational kinds of frameworks that don't necessarily describe the way the world works as much as the way that, in some sense, we might like the world to work. I won't spend any time trying to talk about how it actually does. I know that will be covered to some extent in some of the subsequent presentations. And it also is an area that needs more research and more activity and contributions from all of you. But again, this is an attempt to provide an answer to some of the key questions. What is implementation science? How does it differ from other forms of research? And how do we go about thinking about the design and conduct of a portfolio of implementation studies? So with that, let me stop and open for any questions.
I'll start off with the questions. My name is Kathy Yarkston. I'm at the medical school at University of Washington, up the road ways. And I work with people, adults with motor speech disorders, Parkinson's, ALS, MS. We know a lot about the basic physiology of speech production, and we really are developing a lot of strategies that help people to sound better. It's that implementation part. We get them sounding good in treatment and say, go out and communicate well. You use the term root cause analysis. We know so little about how people with communication disorders function in the real world. Would you talk a little more about what you mean by root cause analysis, and might we implement that in our situation?
So couple of thoughts. One is that if I'm understanding you correctly, I would characterize the issues and the problems that you're describing as within the domain of the clinical research rather than the implementation research. If we talk about the effectiveness or lack of effectiveness of the clinical strategies that are used to support the clients, the patients, and to achieve better performance on their part, and those don't have lasting effects, I would see that as a flaw in what I've labeled the clinical intervention. There probably is a role for root cause analysis in trying to understand what it is about those clinical treatments that don't allow them to have sustained effects. But the implementation research would focus on the goal of trying to ensure that the therapists are delivering those effective clinical strategies. And the root cause analysis in the implementation world is all about what is it about the therapist training or their attitudes towards evidence-based practice or the kinds of constraints that they deal with in their daily work lives, lack of time, lack of support, lack of skill, that prevent them from delivering those therapies with fidelity. But it does sound to me like the problem here is in the limited effectiveness of the clinical treatments.
Let me just give you an example. I really do think it's in the implementation.
Okay.
A lot of the people that we talk to, and we talk to a lot of people about what did you like and not like about our treatment, they say, I was discharged at X amount of time because my funding ran out.
Sure.
And when you go to clinicians, I stopped treatment not because it's not needed, it's because I didn't have the funding.
Right.
So that's not a part of our treatment,
Sure.
It's a part of the implementation policy.
Sure. No, you're right. And in some ways a combination, because a treatment that is efficacious under best case circumstances but is infeasible is not likely to be effective. And the effectiveness or lack thereof, limited effectiveness, is a combination of some features of the treatment that are not scalable, as well as some features of the implementation process in the broader context that doesn't allow the clinicians to provide the proper training and to use the treatment in the way that it was designed and intended to be used. But again, I think the root cause analysis, to get back to your original question, is appropriate for both of those. And it is a matter of understanding, is it a matter of time, comfort on the part of the therapist? Is it a matter of the regulatory or fiscal policies not being supportive? Do we lack the kind of equipment that we need? And so on and so forth. Those are the kinds of potential causes for poor fidelity and poor implementation that we need to understand. Much of the early work in the implementation field in medicine focused on better strategies for continuing medical education. That assumes that the problem is education. Oftentimes clinicians know exactly what to do. They don't have the time, they don't have the staff support, patients are resistant, so there are a number of other barriers, and no amount of continuing education will overcome those barriers. So we're solving the wrong problem. And that's what the root cause analysis or the diagnostic work is all about, identifying the causes so that we can appropriately target the solutions.
And the methods are interviews or going out to stakeholders or looking at databases?
Keep going.
Okay.
Yes, all of the above.
I'm McKay Solberg from the University of Oregon, and I work with folks, I study cognitive rehabilitation with people who have acquired brain injuries. And I'm wondering if you could say a little bit more about kind of the blurriness or kind of trying to handle the blurriness around establishing efficacy, if you really need to have established efficacy before you're going to study the implementation, and maybe ways that, since we can contend with not having that be unidirectional, but the implementation affects the efficacy, as sometimes it's, as you mentioned, it's difficult to, efficacy is established, depends on candidacy issues, it's just not as clear, and that may be answered in your, the notion of implementing hybrid, but I'm maybe pushing you to talk a little bit about the hybrid models.
No, it is, and I think the hybrids relate to both of the previous two questions. And one of the papers that I will circulate lays out the hybrid concepts. But the idea is that this linear process again would take far too long. And we often have enough evidence that something is likely to be effective, and we also have enough concern about the effectiveness depending on the implementation strategy that we really need to do both at once. So there are instances where, first of all, when we're conducting an effectiveness study, we begin to collect implementation-related data. If we are evaluating an innovative treatment in a large, diverse, representative sample of sites, without providing the kinds of extra fidelity support that we do in an efficacy study, that's our best opportunity to begin to understand something about the acceptance and likely use and barriers to appropriate use of that clinical treatment. So we begin to gather implementation-related data. But when we are focusing on the implementation strategy, we need to continue to evaluate the clinical effectiveness and the clinical outcomes. If we have a truly evidence-based practice, and we know from a large body of literature that delivering that practice will lead to better outcomes, we can focus only on implementation. We know that if we achieve increased utilization of that practice, those beneficial health outcomes will follow. But oftentimes the evidence base for the clinical questions is not sufficiently well established. There are interaction effects between clinical efficacy and effectiveness and implementation of fidelity, and we need to be doing both simultaneously. And again, that's what the hybrid frameworks are all about. Studying the success and the effectiveness of a practice change strategy to increase adoption, to increase fidelity, and continuing to measure clinical effectiveness so that we can determine whether we see the benefits as this practice is deployed in real circumstances with different types of implementation support or practice change strategies. So our work on the clinical effectiveness side never ends. And again, distinguishing between these different aims and understanding their implications for sampling and measurement and analysis and so on is one of the key challenges, but one of the goals of the paper that I was involved in drafting with some VA colleagues. So.
Hi, I'm Barry Guitar from the University of Vermont, and The area that I work in is preschool stuttering, and so we've been using a program for about 14 years, adopted from Australia, called the LIDCOM program. And so there are many studies by the group in Australia and ourselves as well showing that it's efficacious. And so now it's important for us to move into the effectiveness domain. But after reading Everett Rogers, I'm highly aware that the context is really important, that the culture is really important. So wondered if you had any tips about how to assess the resistance, because there's a lot of resistance, particularly in the United States, to this program. And I'm thinking, okay, is this a cultural issue? Is it the culture of the speech-language pathologists who are working with preschoolers that has been influenced by some of the belief that you shouldn't talk about stuttering to a preschooler? Or is it a problem of the setting? In other words, is it not easy for the SLPs to make it work in their setting? So any tips?
Again, I think the answer is probably all of the above, but if you recall the query step 3 slide where I showed distinct steps in the diagnostic process, one of those steps is a pre-implementation assessment of barriers and facilitators. And the idea that we spend some time using the methods that were mentioned, interviews and observation and so on, to try to understand and make some educated guesses as to the likely response to an effort to implement this therapeutic approach and to identify some of the key barriers and see what we can do to overcome them. But ultimately, we won't identify those barriers until we actually get out and begin to implement the program. It was Kurt Lewin who talked about the need to attempt to change behavior as a way of understanding barriers rather than in an a priori manner, assuming that we can correctly project them. But there's some other frameworks in the field that focus on the multi-level nature of influences, barriers, constraints to practice change, and talk about the different kinds of strategies that would be needed to address the individual clinician factors, the setting factors, the broader social, cultural, regulatory, and economic factors. And typically the answer to the question, what is impeding implementation, is all of the above. It's all of these factors. And our implementation studies tend to focus on only one or two. If we focus only on education and knowledge, again, we're doing nothing about that broader spectrum of factors. The answer to the question is the barriers and the influences occur pretty much everywhere we look. And it's a much more complicated set of problems, and we need to be thinking about and using, again, another set of frameworks within the implementation science field in health that identify contextual factors, beginning from the regulatory and broadly social, cultural, all the way down to the frontline delivery point of care factors. And think about all of those as potential barriers to practice change, as well as potential targets for our implementation efforts and our practice change efforts.
Thank you. I'm Edie Strand. I'm from the Mayo Clinic. I'm just learning so much. This is just so interesting. And to go back to Kathy's point, for me, the rapid and frequent changes in terms of healthcare reimbursement has caused me havoc in terms of my treatment efficacy research, because in the middle of it, I'm realizing, well, this person isn't going to be able to continue beyond, for example, right now I have a person with severe apraxia of speech who's turning 65 in a month. As soon as she turns 65, there's these serious effects of the therapy cap and all that sort of thing. So they're freaking out and asking me, what are we going to do? Well, we're changing our treatment to bring in the whole family, to do more functional communication. What I really want to do is continue my study